Hello, NCLEX aspirants. Welcome to day 19 of our 30-day NCLEX training series. In today's video, we're diving into practice test number 19, featuring 75 of the most important NCLEX questions. What makes these questions so special? Well, they've been asked 5 to 10 times in the last 5 years. And yes, they have a high chance of showing up on your NCLEX exam. But that's not all. I've got a proven technique that can help you pass your NCLEX on the first attempt. Ready for it? Here's what you need to do. Watch all 30 practice test videos over the next 30 days. Watch each video 3 times. Yes, 3 times, to make sure you absorb every detail. By doing this, you'll cover 4,500 NCLEX questions, sharpening your skills and boosting your confidence like never before. So, grab your notepad and get ready to ace these questions with me. Let's make sure you're 100% exam ready. Alright, let's jump into today's 75 high-yield NCLEX questions that could be the key to your success. Stay tuned till the end for tips and rationales to help you think like an NCLEX pro. Let's get started. Hey, future nurses, did you know that this question has been asked 5 times in the last 5 years on the NCLEX? That's right, it's one of those high-yield topics that you can't afford to miss. So grab your notes and let's break this down together. Here's the first question. A nurse is assessing a client during a routine examination and observes the client exhibit a neuromuscular spasm characterized by palmar flexion when a blood pressure cuff is inflated above the systolic pressure for 2 minutes. Which of the following actions should the nurse prioritize? A. Prepare to administer a dextrose infusion for hypoglycemia. B. Request an order for serum magnesium and calcium levels. C. Recheck the blood pressure using the client's thigh. D. Document the finding as a normal response to cuff inflation. Take a moment to think about it. Okay, time's up. If you chose option B, requesting serum magnesium and calcium levels, you're absolutely correct. Let's dive into why this is the right answer and why it's so important for your NCLEX success. What the nurse observed is a positive Trousseau sign. This is a hallmark indicator of severe hypocalcemia or hypomagnesemia. But what exactly is Trousseau's sign, and why does it matter? Trousseau's sign is a clinical test where a blood pressure cuff is inflated above the client's systolic pressure for 1 to 4 minutes. If the client's hand spasms into palmar flexion, that's your sign of hypocalcemia or hypomagnesemia. Calcium and magnesium play critical roles in muscle contraction, nerve conduction, and even heart rhythm stability. When levels are low, the nerves and muscles become overexcitable, leading to signs like Trousseau's. Now, let's quickly bust the myths behind the other options. Option A, administering dextrose for hypoglycemia, is incorrect because this isn't hypoglycemia. Hypoglycemia presents with symptoms like sweating, confusion, or tremors, not neuromuscular spasms. Option C, rechecking the BP on the thigh, is incorrect because changing the BP location doesn't address the underlying issue. It's the electrolyte imbalance we need to focus on. Option D, documenting it as normal, is incorrect because absolutely not. Trousseau's sign is never normal. It's your red flag to investigate further. Here's what you need to remember for the NCLEX. Trousseau's sign is a strong indicator of hypocalcemia or hypomagnesemia. Common causes include hypoparathyroidism, vitamin D deficiency, chronic kidney disease, and diuretics. Prompt action includes ordering serum calcium and magnesium levels, followed by immediate correction if needed. Don't forget, untreated hypocalcemia or hypomagnesemia can lead to serious complications like tetany, seizures, or even cardiac arrhythmias. Now, let's move on to the second question, which is another high-yield topic that has been asked 4 times in the last 5 years. We've included only those questions that are almost certain to appear on your exam, so let's dive in. At 30 weeks gestation, a pregnant client presents with reduced uterine size, decreased fetal movements, and a fetus that is easily outlined on palpation during a routine prenatal checkup. What's the most likely cause? A. Placental abruption. B. Oligohydramnios. C. Polyhydramnios. D. Gestational diabetes. The correct answer is B. Oligohydramnios. Let's unpack why. Oligohydramnios refers to a significant decrease in amniotic fluid. This reduced fluid leads to restricted fetal movements, a smaller uterine size, and makes the fetus easier to palpate due to the lack of cushioning. Why are the other options incorrect? Option A, placental abruption, is incorrect because this condition involves premature detachment of the placenta, typically accompanied by vaginal bleeding, uterine tenderness, and fetal distress, not reduced uterine size or an easily outlined fetus. Option C, polyhydramnios, is the opposite of oligohydramnios. It involves an excessive accumulation of amniotic fluid, which results in a larger uterine size, not a smaller one. Option D, gestational diabetes, often causes macrosomia, a larger fetus, and increased amniotic fluid, leading to polyhydramnios, not reduced uterine size. Key points to remember. Oligohydramnios is linked to reduced amniotic fluid volume, restricted fetal movements, and smaller uterine size. Common causes include placental insufficiency, premature rupture of membranes, or congenital anomalies. Management may involve regular monitoring, amnioinfusion, or early delivery if the condition worsens. Now, let's move on to the third question. We're tackling a question that has been asked 7 times in the last 5 years on the NCLEX exam. Yes, 7 times. That means there's a great chance it could repeat, so stay tuned as we break it down. Here's the question. A client diagnosed with moderate Alzheimer's disease is dining with others in the communal dining hall. About 30 minutes after finishing their meal, they approach the nurse and say, "I haven't eaten yet today. When is breakfast being served?" What is the best response by the nurse that aligns with therapeutic communication principles and ensures the client's dignity is preserved? Option A. You already ate breakfast earlier. Let's wait until lunchtime. Option B. I can get you a snack if you're feeling hungry. What would you like? Option C. I will check with the kitchen about your breakfast and let you know. Option D. Let's sit down, and I'll bring you some toast or a light snack while we wait for lunch. Let's analyze these options. Option A may be factual, but it could frustrate or embarrass the client. Challenging their memory loss is not therapeutic. Option B offers a snack, but it lacks the reassurance and dignity the client needs. Option C adds confusion by implying a mistake might have occurred, which is unnecessary. Option D is the best choice. It meets the client's immediate needs while preserving their dignity and providing reassurance. Why is option D correct? It validates the client's feelings, offers a solution, and avoids confrontation. It's compassionate and therapeutic, addressing their needs without causing agitation. Now, let's review the nursing responsibilities in similar situations. 1. Therapeutic communication. Avoid arguing or contradicting. Acknowledge feelings and reassure. 2. Nutritional needs. Monitor intake and ensure adequate food and hydration. 3. Preserving dignity. Alzheimer's clients can feel embarrassed by memory lapses, so protect their self-esteem. 4. Care planning. Use individualized strategies like scheduled snacks. 5. Observation. Track patterns of confusion to improve care plans. Are you ready to tackle another high-yield NCLEX question that has been asked 7 times in the past 5 years? Yes, you heard that right. This question has a great chance of being repeated in your exam. Let's dive in and ensure you're fully prepared. Here's the question. A nurse is providing discharge teaching to a client prescribed allopurinol for chronic gout. Which statement by the client indicates a need for further education? A. I will drink at least 3 liters of water daily to help my kidneys eliminate uric acid. B. If I notice a rash or itching, I should stop the medication immediately and notify my provider. C. I can expect my gout symptoms to improve within the first week of starting this medication. D. I will avoid consuming alcohol and high purine foods like organ meats and shellfish. Take a moment to think about your answer. Remember, the question asks for the incorrect statement, the one that indicates a misunderstanding. Let's break this down. Option A. I will drink at least 3 liters of water daily to help my kidneys eliminate uric acid. This is a correct statement. Staying hydrated is crucial for clients on allopurinol because it helps prevent the formation of uric acid crystals in the kidneys. This shows proper understanding and is not the answer we're looking for. Option B. If I notice a rash or itching, I should stop the medication immediately and notify my provider. This is also correct. A rash can indicate hypersensitivity or a severe reaction like Stevens-Johnson syndrome. Stopping the medication and notifying the provider is the right course of action, so this is not the answer. Option C. I can expect my gout symptoms to improve within the first week of starting this medication. Here's the incorrect statement. Allopurinol does not provide immediate relief. It takes weeks or even months for the medication to lower uric acid levels and reduce gout symptoms. This reflects a misunderstanding, making it the correct answer to the question. Option D. I will avoid consuming alcohol and high purine foods like organ meats and shellfish. This is another correct statement. Avoiding high purine foods and alcohol is essential for managing gout and reducing uric acid levels. Therefore, this is not the answer we're looking for. The correct answer is C. I can expect my gout symptoms to improve within the first week of starting this medication. It's important to note that the question specifically asks for the incorrect statement, so your focus should be on identifying the option that reflects a misunderstanding. The other options are correct and demonstrate proper knowledge. The nurse must also know what gout is. Gout is a type of inflammatory arthritis caused by elevated levels of uric acid in the blood, a condition called hyperuricemia. Now, why is this a problem? When there's too much uric acid floating around, it starts to crystallize into sharp, needle-like structures. Imagine tiny shards of glass depositing into your joints, tissues, and even organs. Ouch, right? These crystals lead to severe pain, swelling, and redness. Here's an interesting fact. Gout commonly attacks the big toe, and this is known as podagra. It's like the big toe becomes the body's most dramatic alarm system. If gout is not well controlled, over time, the uric acid crystals can start to accumulate in soft tissues, forming hard, visible lumps called tophi. Let's go over some key nursing responsibilities for clients on allopurinol. 1. Monitor for hypersensitivity reactions. Rash or signs of Stevens-Johnson syndrome require immediate discontinuation and medical attention. 2. Timing of medication. Instruct clients to take allopurinol after meals to reduce gastrointestinal upset. 3. Encourage compliance. Emphasize sticking to the prescribed regimen, even if symptom relief takes time. 4. Renal and liver function monitoring. Regular testing is essential since allopurinol can affect these organs. 5. Dietary counseling. Reinforce a low purine diet by avoiding red meat, organ meats, and shellfish. 6. Avoid triggers. Limit alcohol and sugary beverages, which can exacerbate gout. This question highlights the importance of distinguishing between correct and incorrect client statements, an essential skill for the NCLEX and real-world nursing. Are you ready to tackle the 5th high-yield NCLEX question that has been asked 10 times in the last 5 years? This question is favored by the board. That's right, mastering this one might just secure you another critical point on your exam. All right, let's dive in. You're a nurse caring for a client receiving nitroglycerin therapy for acute angina. The question is simple, yet critical. Which of the following nursing actions is the priority? Here are your options. A. Monitor the client's blood pressure closely for hypotension. B. Assess the client's respiratory rate for signs of respiratory depression. C. Measure the client's urinary output every 4 hours. D. Evaluate the client's apical heart rate before administration. Take a moment to think. Which one would you choose? Answer reveal. And the correct answer is A. Monitor the client's blood pressure closely for hypotension. Here's the rationale. Nitroglycerin is a potent vasodilator, meaning it widens the blood vessels. While this helps decrease the workload on the heart, it also significantly lowers both preload and afterload. That's great for relieving angina, but it can also lead to serious hypotension, and that's something we, as nurses, need to catch early. That's why monitoring the client's blood pressure is the priority action. Early detection and management of hypotension can prevent complications. Addressing the incorrect options, now let's quickly go through why the other options don't take the top spot. Option B. While monitoring respiratory rate is critical for clients on opioids or sedatives, nitroglycerin doesn't directly affect respiratory function. Option C. Measuring urinary output is important, but it's not directly influenced by nitroglycerin therapy. It only becomes a concern if hypotension reduces renal perfusion. Option D. Checking the apical heart rate is part of general cardiac care, but for nitroglycerin, the primary concern is blood pressure due to the risk of vasodilation-induced hypotension. Let's move to the 6th NCLEX review question. This question has been asked 8 times in the last 5 years on the NCLEX. That's right, this question has a great chance of showing up again, so let's make sure you're fully prepared. A nurse caring for an older adult client with advanced dementia who repeatedly attempts to get up from their wheelchair unassisted despite multiple redirection attempts. The client has fallen twice, sustaining minor bruises. The primary healthcare provider prescribes a restraint for safety. Which nursing intervention demonstrates appropriate care in this situation? Let's look at the options. A. Apply a waist belt restraint securely over the client's gown and anchor it to the movable side rail of the bed to allow adjustments. B. Implement a waist belt restraint, ensuring it is secured to the immovable part of the wheelchair frame and monitoring the client every 4 hours. C. Secure a soft wrist restraint to limit the client's upper extremity movements and prevent further falls. D. Apply a waist belt restraint over the client's clothing, secure it to an immovable part of the wheelchair, and assess the client's skin integrity and circulation every 2 hours. The correct answer is D. Let's break it down to see why this is the safest and most effective choice. First, the waist belt restraint should be applied over the client's clothing. This reduces the risk of skin irritation or injury, which is a small step with a big impact on patient comfort and safety. Second, the restraint must be secured to an immovable part of the wheelchair. This ensures the client's safety by preventing falls and any unsafe movements. Third, nurses must regularly assess the client's skin integrity, circulation, and comfort every 2 hours. This helps prevent complications like pressure ulcers or restricted blood flow. Also remember, restraints are always a last resort. Nurses must continuously reassess the need for restraints and explore alternatives whenever possible. Now, let's look at why the other options don't make the cut. Option A. Anchoring the restraint to a movable side rail is unsafe because adjusting the rail could cause injury. Always secure restraints to immovable parts for stability. Option B. Monitoring every 4 hours is just not enough. Frequent checks, at least every 2 hours, are necessary to ensure safety and prevent complications. Option C. Soft wrist restraints are designed to limit upper extremity movement, like preventing the client from pulling out medical devices. They are not suitable for preventing falls from a wheelchair. Let's dive into the next most frequently asked NCLEX question that has come up 7 times in the last 5 years. Yes, 7 times. This means it is a must-know topic with a high chance of showing up on your exam. Ready? Let's go. A nurse is inserting an indwelling urinary catheter in a male client and is preparing to inflate the catheter's balloon. Which action demonstrates the correct nursing practice to prevent complications during this procedure? Here are your options. A. Inflate the balloon immediately upon observing urine flow in the catheter tubing. B. Advance the catheter to the bifurcation point before inflating the balloon. C. Inflate the balloon when resistance is encountered during catheter insertion. D. Fully advance the catheter length into the bladder before inflating the balloon. Take a moment. What's your answer? Got it? Let's break this down together. The correct answer? It's B. Advance the catheter to the bifurcation point before inflating the balloon. Why is this the correct choice? Here's the logic behind it. Look for urine flow first. When you see urine in the catheter tubing, it confirms you're in the bladder. Don't rush to inflate the balloon just yet. Advance to the bifurcation point. Keep pushing the catheter gently until you reach the bifurcation point. This is the Y junction where the balloon inflation port meets the catheter. Why is this important? It ensures the balloon inflates inside the bladder and not in the sensitive urethra, which could cause trauma or damage. Inflate the balloon safely. Once at the bifurcation, inflate the balloon with the recommended volume of sterile water. Gently adjust. After inflating, gently pull back the catheter until you feel resistance, then advance it slightly. This final step positions the catheter properly without putting pressure on the bladder neck. What about the other options? Let's clear up any confusion. Option A. Inflating the balloon immediately when you see urine is a common mistake. The catheter might still be in the urethra, leading to injury. Option C. Inflating the balloon when you feel resistance? That's not safe. Resistance could mean the catheter isn't in the bladder yet, and inflating here could worsen the situation. Option D. Fully advancing the catheter to its maximum length is unnecessary and can cause discomfort for the patient. Key takeaways. To prevent complications, always remember, urine flow confirms entry into the bladder. Advance to the bifurcation point for correct placement, and inflate the balloon only after reaching the bifurcation. Here's the next high-yield NCLEX question that has been asked 4 times in the last 5 years. There's a great chance it might show up again. A 54-year-old client presents to the clinic reporting irregular periods and experiencing symptoms of hot flashes over the last several months. She also shares a positive home pregnancy test result and says, "I didn't think this was possible at my age." As the nurse, what is your best initial response? A. Congratulations! Let's start planning for your prenatal care. B. Let's discuss your symptoms further and confirm the result with a transvaginal ultrasound. C. It's not unusual for women in their 50s to have false positive pregnancy tests due to hormonal changes. D. We should repeat the urine pregnancy test to confirm the result before proceeding. Take a moment to think about your answer. Got it? Let's break it down. The correct answer is B. Let's discuss your symptoms further and confirm the result with a transvaginal ultrasound. Here's why this is the best choice. At 54 years old, the client is likely in premenopause, where hormonal changes can mimic pregnancy symptoms like irregular periods and hot flashes. False positive pregnancy tests can occur during this stage due to elevated beta-HCG levels, either from hormonal changes or potential pathologies like trophoblastic tumors. A transvaginal ultrasound is the most reliable diagnostic tool to confirm or rule out pregnancy. Alternatively, serial serum beta-HCG levels can provide additional clarity by tracking trends. Now, let's quickly review why the other options are incorrect. Option A assumes pregnancy is confirmed without proper testing. This can mislead or distress the client if the result is a false positive. Option C dismisses the possibility of pregnancy too soon. While false positives are common in older women, pregnancy is still possible in premenopausal women, so the nurse must remain unbiased. Option D suggests repeating a urine pregnancy test, which does not add diagnostic value. Urine tests can still yield false positive results, so ultrasound or serum beta HCG testing is the preferred approach. Here's the next question that has been asked 3 times in the last 5 years. A 75-year-old client comes in for a routine checkup and asks about eye health. They want to know what vision problems might occur with aging. What should the nurse emphasize as the most significant age-related risks and the associated nursing responsibilities? Here are your options. A. Myopia and astigmatism with regular prescription updates. B. Blepharitis and chalazion with warm compresses as needed. C. Glaucoma and cataracts with a focus on regular screenings and early detection. D. Exophthalmos and presbyopia with referrals to an endocrinologist when indicated. The correct answer is C. Glaucoma and cataracts. Now, let's go step by step to understand why this is the best choice. First, let's talk about glaucoma. Glaucoma is a condition that damages the optic nerve. It's often caused by increased pressure inside the eye, and here's the critical part. If it's left untreated, it can lead to blindness. That's why regular screenings are so important. Early detection can literally save someone's vision. Now, let's move on to cataracts. Cataracts cause the lens of the eye to become cloudy, leading to gradual vision loss. They're incredibly common as people age. The good news, cataracts can usually be treated with surgery, and most clients regain their vision afterwards. So, as a nurse, your responsibility is clear. Emphasize the importance of regular eye exams and educate your clients on early detection. These are the most significant risks for older adults, as managing them properly can make a huge difference in their quality of life. Now, why are the other options wrong? Let's break them down quickly. Option A. Myopia and astigmatism are common refractive errors, but they're not specifically age-related. They're not the big risks we're worried about in older adults. Option B. Blepharitis and chalazion? Sure, these conditions happen at any age, but they don't lead to serious vision loss. Not a priority here. Option D. Presbyopia is just a normal part of aging. It's when people need reading glasses. No big deal. And exophthalmos? That's related to thyroid problems, not aging. So, the other options are either not age-specific or not significant risks. Now we're diving into a critical neonatal intensive care unit NICU scenario-related question that has been asked 6 times in the last 5 years on the exam. January 2019, April 2019, August 2020, March 2021, July 2023, and October 2024. Here's the question. You're a nurse in the NICU caring for a newborn with some unusual findings. Here's what you observe. 1. Asymmetrical perfusion. The upper body looks different from the lower body. 2. Bounding 3+ radial pulses. Strong pulses in the arms. 3. Faint 1+ pedal pulses. Weak pulses in the legs. 4. Warm, pink hands. Good circulation in the upper extremities. And 5. Pale, cold feet. Poor circulation in the lower extremities. Additional assessments show delayed capillary refill in the lower extremities, oxygen saturation differences, 95% in the right hand, but only 82% in the right foot. No cyanosis, but the baby struggles with feeding and becomes fatigued. Now, based on this clinical picture, which congenital cardiac defect is most likely? Here are your options. A. Tetralogy of Fallot, TOF. B. Hypoplastic left heart syndrome, HLHS. C. Coarctation of the aorta, COA. D. Transposition of the great arteries, TGA. Let's tackle these one by one and use elimination to find the best answer. Option A. Tetralogy of Fallot, TOF. TOF has 4 key features: pulmonary stenosis, right ventricular hypertrophy, overriding aorta, and ventricular septal defect, VSD. Babies with TOF often present with cyanosis and a murmur, neither of which is seen in our baby here. The asymmetrical perfusion described doesn't fit TOF's pathophysiology, so this is not the answer. Option B, hypoplastic left heart syndrome, HLHS. In HLHS, the left side of the heart is underdeveloped. This results in systemic hypoperfusion, which would affect the entire body, not just the lower extremities. Cyanosis and a murmur are usually present, but we don't see those here. HLHS doesn't explain the warm upper body and cold lower body, so this is also incorrect. Option D, transposition of the great arteries, TGA. In TGA, the aorta and pulmonary artery are swapped. This creates two separate circulatory systems. Babies with TGA present with severe cyanosis unless there's a shunt allowing blood to mix. The pink upper body and pale lower body don't align with this diagnosis. Therefore, this isn't the answer either. Option C, coarctation of the aorta, COA. Now, let's look at COA, the narrowing of the aorta, often near the ductus arteriosus. This narrowing reduces blood flow to the lower body while increasing pressure and perfusion to the upper body. This explains the bounding radial pulses and warm pink hands, faint pedal pulses and pale cold feet, and the oxygen saturation difference between the right hand, preductal, and right foot, postductal. Feeding difficulties? Makes sense too. The heart is working harder, leading to fatigue during feeding. So, the correct answer is C, coarctation of the aorta. To summarize, coarctation of the aorta creates a clear divide in blood flow between the upper and lower body. Upper extremities, increased perfusion, warm, pink, strong pulses. Lower extremities, decreased perfusion, pale, cold, weak pulses. Oxygen saturation differences between pre- and postductal areas seal the diagnosis. Let's move to the next question that has appeared 7 times in the last 5 years on the NCLEX exam. February 2019, June 2019, December 2019, May 2020, September 2021, April 2023, and September 2024. A nurse is assessing a client who presents with diminished pedal pulses, loss of hair on the lower extremities, and a well-demarcated, full-thickness ulcer with minimal serous exudate on the right lateral malleolus. The client's history includes intermittent claudication and a 30-year smoking history. Which of the following interventions is inappropriate for this client? A. Elevate the affected limb above heart level to improve circulation. B. Assess the client's readiness to participate in smoking cessation. C. Refer the client for a supervised exercise therapy program. D. Perform an ankle brachial index ABI assessment using a Doppler device. Alright, first let's analyze the question. The client shows classic signs of peripheral arterial disease, PAD, diminished pedal pulses, hair loss on the lower extremities, and that well-demarcated ulcer. They also have risk factors like intermittent claudication and a 30-year smoking history. Now, let's break down the options to determine which intervention is inappropriate. Option A. Elevate the affected limb above heart level to improve circulation. This might seem logical at first, but remember, in arterial insufficiency, elevating the limb reduces blood flow even further. Why? Gravity plays a role in helping blood reach the extremities when circulation is already impaired. In fact, elevating the limb can worsen ischemia, making symptoms like pain more severe. Instead, we should position the limb below heart level to promote blood flow. So, option A is the correct answer, because it's inappropriate for a client with PAD. Option B. Assess the client's readiness to participate in smoking cessation. This is an appropriate intervention. Smoking is a major risk factor for PAD because it damages blood vessels and worsens arterial insufficiency. Encouraging the client to quit smoking is a critical part of their care plan. This option is definitely appropriate. Option C. Refer to the client for a supervised exercise therapy program. Another appropriate intervention. Supervised exercise therapy, especially walking programs, helps improve intermittent claudication symptoms. It works by promoting the development of collateral circulation, essentially creating new pathways for blood to flow around blocked arteries. This is a great strategy for PAD management. Option D. Perform an ankle brachial index ABI assessment using a Doppler device. This is also appropriate. The ABI test is essential for diagnosing PAD. It measures the ratio of blood pressure in the ankle to the blood pressure in the arm, giving us a clear picture of the severity of arterial insufficiency. So, this intervention is definitely needed. So, to summarize, Option A is inappropriate because elevating the limb above heart level worsens arterial insufficiency. Options B, C, and D are all appropriate interventions for managing PAD. Remember this tip. Arterial ulcers and PAD require us to think about improving blood flow downward. Gravity is your friend. Now we're diving into a key question about monitoring a client receiving norepinephrine infusion for the management of septic shock. This has been asked 8 times in the last 5 years, so it is super important for the NCLEX exam. Referenced March 2019, July 2019, November 2019, June 2020, January 2021, September 2022, May 2023, and August 2024. Alright, here's the scenario. A nurse is monitoring a client on norepinephrine infusion. The goal of the medication is to manage septic shock by improving organ perfusion. So, the question is, which finding indicates that the medication is working as intended? Let's go through the options carefully. Option A. Increased urine output and capillary refill time greater than 3 seconds. Okay, so increased urine output sounds good, right? It shows that the kidneys are getting better perfusion, but capillary refill time greater than 3 seconds means poor blood flow to the extremities. That's a red flag for ongoing hypoperfusion. This option is incorrect. Option B. Mean arterial pressure, MAP, is greater than 65 mmHg and improved mental status. MAP is one of the most reliable indicators of adequate organ perfusion. An MAP of at least 65 mmHg means the organs, including the brain, are getting enough blood flow. Improved mental status? That's a sign the brain is happy. This option fits our therapeutic goal perfectly. Keep this one in mind. Option C. Heart rate below 60 beats per minute. Brachycardia. Norepinephrine acts on adrenergic receptors, which usually increase heart rate, not lower it. Brachycardia isn't a typical response to this medication, so this option doesn't make sense. Option D. Respiratory rate below 12 breaths per minute with a weak peripheral pulse. A weak peripheral pulse and a slowed respiratory rate indicate worsening perfusion and potentially adverse effects of the medication. Definitely not what we're aiming for. So this option is also incorrect. So the correct answer is B. Mean arterial pressure, MAP, greater than 65 mmHg and improved mental status. These findings show that norepinephrine is achieving its intended goal of maintaining adequate organ perfusion. Let's quickly review how norepinephrine works. It's a vasopressor, which means it causes blood vessels to constrict by stimulating alpha-adrenergic receptors. This increases systemic vascular resistance and raises blood pressure. It also has a mild effect on beta-adrenergic receptors, which can increase heart rate slightly. During infusion, we closely monitor the MAP, urine output, heart rate, and mental status to assess effectiveness. Often, an arterial line is used for accurate blood pressure measurement. Here are your NCLEX nuggets for norepinephrine and septic shock. 1. Goal MAP. Keep it at or above 65 mmHg. 2. Improved mental status. Sign of better cerebral perfusion. 3. Continuous monitoring. Watch MAP, heart rate, urine output, and mental status. And 4. Adverse effects. Avoid excessive vasoconstriction and ischemia. Let's move to the next question. This question has been asked 4 times in the last 5 years on NCLEX exams. February 2019, June 2020, April 2023, and July 2024. Let's start with a clinical scenario to test your knowledge. You're a nurse caring for a male client diagnosed with secondary syphilis. During your assessment, you need to determine which finding indicates the progression to the secondary stage. Here are your options. A. Generalized mascular rash on palms and soles. B. Painless chancre at the site of infection. C. Foul-smelling penile discharge. D. Painful inguinal lymphadenopathy. The correct answer is A. A generalized mascular rash on the palms and soles. Let's break this down step by step. Choice A. Generalized mascular rash on palms and soles. This is correct because secondary syphilis caused by the bacterium Treponema pallidum is known for systemic manifestations. The hallmark sign of the secondary stage is a mascular or papular rash, especially noticeable on the palms and soles. Other signs in this stage include fever, malaise, and generalized lymphadenopathy. Choice B. Painless chancre at the site of infection. This one is incorrect because a painless chancre is specific to the primary stage of syphilis. This chancre appears at the infection site and resolves before secondary symptoms develop. Choice C. Foul-smelling penile discharge. Also incorrect. Syphilis does not cause foul-smelling discharge. If you encounter such symptoms, think about infections like gonorrhea or trichomoniasis. Choice D. Painful inguinal lymphadenopathy. Lastly, this is incorrect too. While syphilis in the secondary stage can cause generalized lymphadenopathy, it's typically non-painful. Painful lymphadenopathy is more indicative of conditions like chancroid or lymphogranuloma venereum. Now, let's quickly review the stages of syphilis as this can show up in your exams. 1. Primary stage, characterized by a painless chancre at the site of infection. 2. Secondary stage. This is where we see systemic symptoms like a diffuse rash, especially on the palms and soles. Other features include mucus patches and flu-like symptoms such as fever and malaise. 3. Tertiary stage. This stage can occur years later with severe complications like cardiovascular damage, neurological issues, or gumatose lesions. Finally, let's touch on management. For early-stage syphilis, the treatment of choice is benzathine penicillin G. If the client is allergic to penicillin, doxycycline is a reliable alternative. So remember, for secondary syphilis, look for the rash on the palms and soles. It's a classic NCLEX tip. Now we're tackling a most important question that often appears on the NCLEX. The question is, a 38-week pregnant woman arrives at the emergency department. Her chief complaint? Vaginal bleeding. She denies having any significant pain or contractions, but appears anxious. During your assessment, you notice her vital signs are stable, and there are no signs of uterine tenderness. Which statement by the client would prompt you, as the nurse, to suspect placenta previa as the cause of her bleeding? Let's look at the options together. Option A. I've noticed the bleeding increases whenever I stand up for too long, but there's no pain. The no pain part fits placenta previa, but positional bleeding, bleeding that increases when standing, might suggest something else, like cervical insufficiency or another placental issue, so this is not our best choice. Option B. The bleeding started suddenly without any warning while I was watching TV. This is the key. Sudden, painless vaginal bleeding is a hallmark symptom of placenta previa. This is looking like our correct answer, but let's keep going. Option C. I feel some mild cramping along with the bleeding, but it's not like my usual period pain. Cramping or pain isn't typically associated with placenta previa. If anything, this might make us think about preterm labor or even placental abruption, so this one doesn't fit. Option D. I'm worried because the bleeding started right after I picked up my toddler, who weighs 32 pounds. While heavy lifting might seem concerning, it's not a known trigger for bleeding in placenta previa. This could point us towards other conditions, but it doesn't help confirm placenta previa. So the correct answer is option B. The bleeding started suddenly without any warning while I was watching TV. Why? Because painless, sudden vaginal bleeding is the classic presentation of placenta previa. Let's quickly review what happens in placenta previa. This condition occurs when the placenta implants near or over the cervical os. As pregnancy progresses, the growing uterus and the position of the placenta can cause bleeding. Bleeding in placenta previa is maternal in origin. It is not triggered by mechanical actions like lifting. Pain is typically absent. That's why it's different from placental abruption, where bleeding is accompanied by pain. This question has been asked 8 times in the last 5 years on NCLEX exams: March 2019, August 2019, January 2020, November 2020, June 2021, February 2022, October 2023, and July 2024. A nurse is caring for a client who suddenly collapsed at home. The client is now alert but presents with slurred speech, weakness on one side of the body, and a noticeable facial droop. These are all classic signs of a potential stroke, right? Which additional assessment finding would most strongly suggest that this client is experiencing a stroke? Let me give you the options. A. Tachycardia. B. Anisocoria. C. Dehydration. D. Hyperglycemia. Take a moment and think about it. Which one do you think is the most telling sign that confirms a stroke? All right, let's break this down. First, let's look at tachycardia, option A. Now, can tachycardia happen in a patient with a stroke? Sure, it can. But is it a specific sign of a stroke? No, it isn't. Tachycardia is more of a general response to stress, anxiety, or other underlying conditions, so we can rule that out. Next, we have anisocoria, option B. What does anisocoria mean? Unequal pupil sizes. This is a significant neurological clue. Why? Because it often indicates increased intracranial pressure or brainstem involvement, both of which are associated with a stroke. This is a red flag that the client needs immediate evaluation, so keep this one in mind. Now, on to dehydration, option C. Dehydration could happen in a lot of situations: fevers, vomiting, or even just not drinking enough water. But is it a hallmark sign of a stroke? No. It's not specific enough to strongly suggest a stroke. Lastly, let's discuss hyperglycemia, option D. Hyperglycemia can occur in stroke patients, especially in those with pre-existing diabetes. However, it's more of a secondary issue. It doesn't directly indicate a stroke. So, what's our answer? B. Anisocoria. Why? Because anisocoria gives us a direct neurological sign pointing to brain involvement, which is exactly what we're concerned about in stroke cases. Now, here's the takeaway. When you're assessing a stroke, always think about specific neurological signs. Unequal pupils, immediate red flag. Slurred speech, facial droop, and weakness on one side, stroke, until proven otherwise. Let's move to the next crucial NCLEX question that was tested the most frequently in the exam. A client is brought to the emergency department after intentionally ingesting an overdose of amitriptyline. The question asks, which assessment should the nurse prioritize to guide immediate intervention? Your options are A. Exact number of tablets ingested. B. The client's history of mental health conditions. C. Any prior incidents of intentional overdose. D. The client's vital signs and level of consciousness. Let's think about this critically. All of these options seem important, right? But we're asked to identify the priority action. So let's analyze. The correct answer is A. Exact number of tablets ingested. Amitriptyline is a tricyclic antidepressant, TCA. When overdosed, it carries a high risk of cardiotoxicity, which can severely affect the heart, leading to life-threatening complications like arrhythmias. Knowing the exact amount ingested is critical because it helps gauge the severity of the overdose and guide immediate interventions. For example, once we have this information, we can order a 12-lead electrocardiogram, ECG, to look for changes that indicate cardiotoxicity, such as QT prolongation, and initiate continuous cardiac monitoring to catch any abnormal rhythms early. Without this information, we're essentially flying blind in managing the acute phase of this emergency. Now, let's talk about why the other options, while important, are not the priority. B. The client's history of mental health conditions. This helps us understand the bigger picture, like underlying reasons for the overdose, but it doesn't directly guide immediate life-saving interventions. C. Any prior incidents of intentional overdose. This provides valuable context, but again, it's not going to change what we do right now to stabilize the client. D. The client's vital signs and level of consciousness. Yes, this is crucial information for overall assessment, but it's secondary to identifying the potential for cardiotoxicity in planning immediate interventions. Here's a bit more about TCAs like amitriptyline. They're commonly used to treat depression and obsessive-compulsive disorders. Overdose can lead to severe anticholinergic effects like dry mouth, dilated pupils, urinary retention, and confusion. However, the most dangerous complication is cardiotoxicity. In cases of overdose, you may need to administer activated charcoal if the ingestion was recent, provide intravenous sodium bicarbonate for cardiotoxicity, and prepare for advanced cardiac life support if necessary. Every second counts in these emergencies. To recap, when faced with a TCA overdose, your first priority is determining the exact amount ingested. This information directs immediate interventions, helping us identify and manage life-threatening complications like cardiotoxicity. NCLEX tip: always focus on the option that addresses the most immediate threat to life. In this case, cardiotoxicity takes precedence over gathering the client's medical history or past behaviors. Here is the next question. A nurse educator is conducting a seminar on care coordination and the role of interdisciplinary referrals in client management. Which of the following best describes a key objective of interdisciplinary referrals in healthcare? The options are: A. Empowering nurses to assert their leadership and decision-making skills. B. Streamlining care delivery by engaging appropriate specialists for client needs. C. Ensuring a unilateral approach to care that reduces healthcare costs. D. Enhancing client autonomy through self-directed decision-making in care. The correct answer is B. Streamlining care delivery by engaging appropriate specialists for client needs. Let's talk about why this is correct and why the other options are not. Why option B is correct. Interdisciplinary referrals are a cornerstone of care coordination. The goal is to ensure that clients receive the most comprehensive and tailored care by involving specialists who have the expertise to address specific needs. For example, imagine you're caring for a patient with a complicated wound that isn't healing properly. As the nurse, you identify the issue and coordinate a referral to a wound care specialist. This referral ensures the patient gets targeted treatment, such as advanced dressings or therapies that you might not be able to provide on your own. This process streamlines care delivery, ensures effective use of resources, and, most importantly, optimizes client outcomes. Now, let's tackle the other options. Option A. Empowering nurses to assert their leadership and decision-making skills. While nurses play a vital role in care coordination and leadership, the primary focus of referrals isn't to showcase nurse leadership. It's about directing clients to the right specialist to meet their healthcare needs. Option C. Ensuring a unilateral approach to care that reduces healthcare costs. Healthcare is never unilateral. It's all about collaboration. While referrals can help control costs by avoiding unnecessary treatments, their main purpose isn't solely about cost-cutting. It's about providing the right care at the right time. Option D. Enhancing client autonomy through self-directed decision-making in care. Referrals absolutely respect client autonomy, but they're not centered on self-directed decision-making. Instead, referrals focus on engaging expert professionals to achieve the best outcomes for the client. Let's move to the next question. This question has been asked 3 times in the last 5 years: February 2019, September 2021, and May 2024. A nurse cares for a client with an unruptured ectopic pregnancy. The primary healthcare provider chooses a non-surgical approach due to the client's stability. Which medication does the nurse expect? A. Terbutaline. B. Methotrexate. C. Oxytocin. D. Carboprost. Option A. Terbutaline. Terbutaline is a tocolytic used to stop preterm labor by relaxing uterine muscles. It's not relevant for treating an ectopic pregnancy. Eliminate this option. Option B. methotrexate. This is the correct answer. Methotrexate is a folic acid antagonist that stops the rapid cell division of trophoblastic tissue in ectopic pregnancies. It's a non-surgical option for stable clients with unruptured ectopic pregnancies. Remember, it's contraindicated in cases of rupture or organ dysfunction. Option C, oxytocin. Oxytocin is used to induce labor or control postpartum hemorrhage. It has no role in treating ectopic pregnancies. Eliminate this option. Option D, carboprost. Carboprost is used for postpartum hemorrhage or to terminate a pregnancy, not for managing unruptured ectopic pregnancies. Eliminate this option. So the correct answer, B, methotrexate. Why methotrexate? It targets rapid cell division in trophoblastic tissue. It's a non-surgical option for stable clients. When not to use methotrexate: if the ectopic pregnancy has ruptured, if there's organ dysfunction like liver or kidney issues. Nursing responsibilities. As nurses, it's vital to ensure chemotherapeutic safety when administering methotrexate. Educate clients about avoiding alcohol and folic acid supplements. Monitoring for complications like severe abdominal pain, which could indicate rupture.